pull up this up. Okay. You can request sharing, send request. So Saad, if you can just allow me to, okay, thank you. Uh, share. Okay, let me minimize and do this. Okay. So can you confirm what you're seeing on your slides?
Review session, head and neck special senses.
Okay, so do you just see one slide or do you also see the upcoming slide?
No, I just see one slide.
Okay. Okay, so let's begin. My name is Affan. I'm one of the TAs. So today we'll be going over the head and neck and special senses. So as you can already see from this picture, that you have the eye involvement in this picture, you have the brain, you have the, oh, sorry, let me just do the pointer thing. Where is the pointer? Just give me one moment, please. Yes. So as you can see, you have the eye, the nose, the mouth, and the ear, and you can see the eustachian tube. So there are a lot of anatomical structures that come together and work together with the brain to allow the special senses to function. So it's very important that you understand how those different parts play together. For example, the vestibular system relies on inputs from your eyes, from the ear, and then it combines those signals together. So it's very important to kind of know the cases where all of those systems come into play at once. Okay. Now let's go to the next slide. Okay, so let's do a bit of sightseeing. Does anyone know what this is?
No.
Sorry?
I don't know, just a building. I'm not sure where from, to be honest.
Okay. Okay, so this is the external view of Sistine Chapel where they'll hold the conclave. If you go in, this is the Sistine. Sorry?
Sorry?
Someone needs to mute their mic. Okay. As you go in, so this is the Sistine Chapel, and then you see those wonderful frescoes on the wall. And as you go on and look towards the ceiling, so there's this part of the painting. So back in the day, the church did not allow people to actually dissect human beings. So the works of Michelangelo were supposed to be hidden. So what he did is he incorporated them into the picture. So that's how at least the story goes. So as you can see now, this is a paper from the University of Pittsburgh that shows you how the brain anatomical structures and related anatomy were hidden within the frescoes of the Sistine Chapel. Okay, so that's that. Okay. So I know we're no longer doing physical. I know we're doing online sessions, but please stay attentive and please make sure you respond during the talk and respond during the question polls. So we'll be going over the cranial nerves, common ear conditions, anatomical correlations across all the ENT, ophthalmological emergencies, and finally, at the end, we'll be going over what Dr. Shaukat said about the exam. I'd just like to thank Dr. Shaukat, Dr. Hana, and Dr. Maha, as well as everyone in the mentorship team for their wonderful input. Shout out to Dr. Vlad who helped me kind of structure this talk by telling me like what he thinks is important to focus on. And special shout out to my PBL students who gave me wonderful suggestions on how to improve the talk. So the way we'll be doing this is we'll be discussing some topics, going over questions. So please stay interactive. Okay, so the first cranial nerve is olfactory nerve. So we already know it's sensory. It helps in smell. If there's a lesion, the patient will have anosmia. Commonly affected by lesions such as acceleration, deceleration injuries, which can actually lead to avulsion of the olfactory nerve rootlets. What else? If we kind of go here, if they give you that dissection, you can see these crab eye looking nerves are, so where was it? Here, the crab eye looking nerves are the olfactory nerves. Oops. Okay. Going next, the optic nerve. This is a very important, yes, Samir. Go ahead.
Doctor, I don't think we were seeing your pointer on the previous slide. I
Oh,
think we might
okay.
see it. I
Can you
don't know.
see it now?
Yeah, it's coming and going.
Oh, okay. Is it there now? Okay,
Yes,
wait.
like when you move it, it appears. Yeah, so just move it when you want to highlight something.
Okay, so can you see the hand thing?
No.
Okay. Thank you, Samir, for pointing that out. Can you see now? Okay, the thing is, I think when I zoom, you can't see the pointer.
Yeah, probably.
Yeah, so, but you can see it's labeled here, E, so that's olfactory nerve. It looks like crab eyes.
Yep.
Okay. Thank you for pointing that out. Okay, so laser pointer. Okay. So the next nerve is the optic nerve. And what else? It's sensory, it's important for sight, and if you have a lesion, then you may have anopia. Now, this is also the afferent limb of the pupillary reflex. So then, if you have a lesion to the optic nerve, the patient will have relative afferent pupillary defect. We'll go over that shortly, but this is an important anatomic correlation, which I want you to know, is that a couple of different bones form the socket, and you need to know those bones. You can do that in your own time, and there are very important nerves that go across the superior orbital fissure and across the inferior orbital fissure. One of the things I'd like to show you is you can see the extraocular muscles here. Now, this muscle is the inferior rectus. If there is a fracture of the base of the socket, of the eye socket, so then you would expect the fat pad to actually descend downwards, and you would also expect the lateral rectus to get entrapped within that defect. Okay, so that's another common scenario. Um, the optic tract has a lot of lesions associated with it. I know you guys probably took this back in neuro as well, but we'll just be highlighting a couple of additional things as we go. So if you have a lesion here, you'll have a monoocular scotoma. If you have a lesion here, i.e., if you transact all the sensory input that goes in, so then you'll have anopia. If you go over here, C, at the level of the optic chiasm, so then you'll have bitemporal hemianopia. If you go over here at this level where it says D, so then you'll have right nasal hemianopia, and so on and so forth. So just a couple of things to remember. Um, if you see left homonymous superior quadrantopia, so that's pie in the sky as you see here. So how do you relate that? Okay, so if you affect the superior parietal lobe, okay, that's the bomb loop. So then you will have contralateral inferior quadrant visual defect. So if the lesion is superior, the quadrantopia would be inferior and contralateral. If the lesion is inferior, then the lesion would be superior and, of course, contralateral. And a quick way to remember the loops is Meyer's loop is in the temporal lobe because they both have the letter M in them. Again, nothing much to delve here because we've already covered that in neuro. Just want to go over relative afferent pupillary defect. So we know that the light enters the retina, as you can see here, and the signals are transmitted via the optic nerve. They go to the pretectal nuclei, which are here, and then bilateral Edinger-Westphal nuclei are activated, and then this is transmitted forward, which leads to bilateral pupillary constriction. Now, this is a direct and consensual reflex. If I illuminate this eye, at the end, both eyes will both eyes will experience pupillary constriction. However, if I sever the optic nerve here and I provide light to this eye, now your efferent limb is working perfectly fine, right? All the extraocular muscles are doing their job. The ciliary muscles are all okay. But the problem here is that the afferent limb, i.e., the sensory part, is not working. So there is no way for this eye to know that you are being exposed to light. So there will be no pupillary constriction. However, remember, the optic nerve is damaged here. If you go on the other side where the optic nerve is working and I shine my light here, so you have already given the sensory input for the light, right? So you will have bilateral pupillary constriction. Okay. Okay, so next we come to cranial nerve 3. Cranial nerve 3 is unique in that it is somatic motor. So all extraocular muscles except lateral rectus, which is innervated by cranial nerve 6, and the superior oblique, which is innervated by cranial nerve 4. It also helps in eyelid opening by the levator palpebrae superioris. What else? Yes, and it's also parasympathetic. For example, the pupillary constrictor in the light reflex and the ciliary muscle, which aid accommodation. Now, the way the fibers are arranged is that the motor fibers are in the center and the parasympathetic fibers are wrapped around the motor fibers. So, why is that important? Well, they can always bring a question if there's an aneurysm or a mass that is going to impinge or compress the nerve. So the parasympathetic fibers will be affected first. So that means you will have a blown out pupil. On the other hand, if you look at the pointer, now I'm in the center. Now, I hope you guys remember that there are tiny blood vessels that supply our nerves, and those can be affected in diabetic patients. So if that happens, the damage will start from the innermost layer here. So within the somatic motor component of the cranial nerve 3. So then the pupillary reflex may be fine, but you'll have problems with the extraocular movements. So you can have paralysis of the supplied extraocular muscles. So basically, you'll have down and out pupil, ptosis because of the innervation of levator palpebrae, dilated pupil once you lose that parasympathetic wrapping, and loss of accommodation reflex because you are taking away the innervation of the ciliary muscles. Okay. So next slide, just to give you a few clinical scenarios which can come in handy. So if you have a hematoma, which you took in your neuroblock, so that can lead to herniation. Now, again, when we talk about herniation, remember, it will start to hit from the outside and then proceed to go all the way in. So that's the way the pressure will work. So you will lose the parasympathetic function first, and then you'll lose the somatic motor function. So just remember that. Another clinical tie-in would be the cavernous sinus. And, all of these very important cranial nerves go through the cavernous sinus. And I'm sure you guys are probably familiar by the valveless facial veins, which drain eventually into the cavernous sinus, and they are valveless. So an infection in that danger triangle can also lead to cavernous sinus thrombosis. Anyways, coming back. We discussed diabetic ophthalmoplegia, where you have damage to cranial nerve 3, a central infarction, and that will lead to down and out pupil, normal sized reactive pupil, because remember, nothing has happened to the parasympathetic coating yet, and you have ptosis. However, if there is aneurysmal compression, you will have a blown out pupil. So if in the clinical scenario you have a blown out pupil, remember, this is something that is really fatal because that aneurysm could just burst in there. Okay. However, remember, once the pressure keeps on building, you're going to eventually hit that core, which we discussed. So you will eventually have ptosis and ophthalmoplegia at the end. Okay. We already discussed this. Just to show you what the accommodation reflex is, because there tends to be a lot of confusion. So you ask the patient to focus on a distant object, for example, a clock on a wall or the light switch in your clinic. Then you place your finger, as you can see here, 20 to 30 centimeters in front of their eyes, or, you can use the patient's own thumb and ask the patient to switch from looking at the distant object okay, which is the light switch or such, to the nearby finger or thumb. And then you should see the pupils, observe the pupils. And what do you expect? Well, you expect constriction and convergence, and that's accommodation. So if you notice clearly, so you can see convergence, okay, and you also see constriction. Okay. Next, we have the trochlear nerve, which is motor. It supplies the superior oblique, which is important in abduction, abduction, internal rotation, and depression while being adducted. Lesions can lead to diplopia. Eye will be in hypertrophy and extorsion. The classic scenarios are usually, this patient has a hard time reading books, can fall downstairs. So that's a classic MCQ scenario. Now, the interesting thing is I can demonstrate this in the next slide, is that the head is always tilted away from the affected side to compensate. So a tricky question can say the patient had difficulty seeing, but now the patient also has neck pain because she has felt like her neck, she keeps on bending her neck. That's what her family noticed. So, just remember, once you know a concept, think of different ways that this can be tested. So remember, neck pain can be one of the symptoms, but we often don't mention it. So that can also be a clue in the MCQ. Anyways, so the head is tilted away from the affected sides, and you have hypertropia and extorsion. Okay, now we're coming to, I guess, all of your favorite nerve. It's cranial nerve number 5. First of all, we know it's sensory. V1, V2, V3 are the three branches, and it also takes somatic sensation from anterior 2/3 of the tongue. Now, it's very, very important to know that this is how the distribution is: V1, V2, and V3. Because you see, if you look closely, if you look at the lips. Now, let me ask you guys a question. There is this patient, he has a painful rash on the upper lip. Which nerve transmits the pain?
V2.
Very good. So that's the thing I want to get, because you see, once they target the lip, they can know whether you know or not. Very good. Okay. And the tip of the nose?
Ophthalmic.
Sorry? Let me check the chat. Are you guys writing there? Okay, yes, it's V1.
Yeah, ophthalmic.
Yes, very good. So this is very important to know, because this tests your anatomy very, very well. Now, a lesion will lead to numbness in the face, and loss of the afferent limb of the corneal reflex. So I know you guys are probably familiar with the corneal reflex now. So this is the afferent limb. Now, that's all sensory, what we discussed. Now, motor is mainly via V3, and it too has further divisions, as you can see. Now, it's important for mastication. It also innervates the tensor tympani, which dampens loud noises, and some of the neck muscles as well. Okay, what else? A common question would be if the patient has a damage to, let's say, the lower part of the eye socket, or they have a blowout fracture to the lower part of the socket. So what can happen? You can damage the infraorbital nerve. So you would have numbness and paresthesia of the upper cheek, upper lip, and upper gingiva. And what else? Yeah. So if you have a V3 injury and you lose innervation to the tensor tympani, so you would no longer be dampening the sound transmission. So what would happen is you would kind of develop that hyperacusis. Okay. Just to go on. So there are, again, we talked about the muscles of mastication. You need to know that. The mandibular division of the trigeminal nerve. Now, this is an interesting reflex, the jaw jerk reflex. Now, both the afferent and efferent is mediated by cranial nerve 5, but I need you guys to always remember, this is not a normal reflex. This is only present when you have injuries. So do not expect this in all patients. Now, going forward, this is just again to emphasize this further, that you need to know the sensory innervation of the trigeminal nerve. And another common question they ask is the ear, right? So the ear can be, you can see this part is innervated by the facial nerve. So that's also another thing I wanted to add here. Remember the lips thing and remember the nose thing. Okay. Yep, we've discussed that. Again, another question would be they can give you an example of corneal abrasion. So I know you haven't taken ophthalmology yet, but a corneal abrasion is when you actually abrase the cornea. I know that's kind of very simplistic. What I'm trying to say is you have trauma or foreign body or if there's a worker and they were cutting steel or something, the foreign body or debris from that steel go on and, they damage the corneal epithelium. This is also common in people who use contact lenses a lot, and they don't take them out. So eventually, you create defects in the corneal epithelium. So the question can be, why do these patients feel pain? Right. So that can be again due to the trigeminal nerve because that's the sensory innervation. And eventually, you should be doing fluorescein exam. So let me just quickly tell you about the fluorescein exam. We put a dye, and that dye shows you the defects under blue light. Okay, so once you put that dye, you put in some blue light, you will see which areas have defects in it or which areas have holes in them. Okay, so that's what it all means. So that can be a tie-in between ophthalmology and your clinical anatomy. Okay. Now we're talking about cranial nerve 6, the abducens nerve. It basically innervates the lateral rectus. However, there are a couple of clinical tie-ins. Remember, the eye will be deviated medially. The patient will have horizontal diplopia. Now, I hope you guys already remember that this is one of those nerves that passes through the cavernous sinus. In fact, it abuts the internal carotid artery. So, if you have an aneurysm of the of the internal carotid artery, you are going to have impingement of cranial nerve 6. That's the first nerve to go away. And raised ICP is also one of the other causes. And what's interesting, tie-in for USMLE, as some of our colleagues requested, is bilateral abducens nerve palsy is seen in Wernicke-Korsakoff syndrome. That's something we all forget, but very high yield for the boards. Okay. Going forward, okay, here's the picture. So you can see the internal carotid artery. Here you see the abducens nerve. So once you have an aneurysm, the first nerve that's gonna be damaged is going to be cranial nerve 6. Okay. Okay. Here we have cranial nerve 7. So 7 is kind of like a hook because it closes the eye, and cranial nerve number 3 are like 3 pillars that open the eye. Okay. We know that it's sensory from anterior 2/3 of the tongue. It is motor to the facial muscles, including the orbicularis oculi and the stapedius, which is also important for volume modulation. It's also parasympathetic to the submandibular and sublingual salivary glands. An important thing to remember is that the facial nerve divides within the substance of the parotid gland, which should be somewhere here. However, it does not innervate the parotid gland. Okay, so now we will divide these lesions further into upper motor neuron and lower motor neuron lesions. First of all, you should know the facial nerve goes through the temporal bone. Okay, and it has different segments. So it has the mastoid segment, for example. As you can see, it also goes intimately behind the tympanic membrane. And you have, which is also the tympanic segment, you have the labyrinthine segment, so it's all over the place. And as you can see, it divides within the substance of the parotid gland. However, a tumor of the parotid gland can eventually compress the facial nerve. And can someone tell me which cranial nerve innervates the parotid gland? Okay, we have something in the chat. Okay, very good. So that's cranial nerve number 9. Very good. Okay, great job. Okay, next. Okay, so now we'll be going over some mnemonics as well, okay? So you already know from neuro that this is kind of how the facial nerve works. So The upper division has bilateral upper motor neuron innervation. However, the lower division just has one innervation. So if the lesion is central, the signs will be contralateral to the lesions. Okay, C for C. If the lesion is peripheral, i.e. the lower, i.e. somewhere here, then the signs will be ipsilateral to the lesion. Now, the way I discussed it in neuro with my people group was like, let's say if you have a lot of stuff, a lot of hardwiring going on, and then you eventually descend. Now, if I were to damage something here, it is most likely going to affect this side of things, right? It's going to affect this side of things, right? So contralateral, because it's all haywire here. However, if I do a transaction here, so then you are going to see the effects ipsilaterally. That's another way of thinking this through. Now, the ability to, again, let's discuss this in further details in the next one. So I can give you the hints as well. So of course, okay. So A is central and this is peripheral. Okay. So the ability to frown is lost in the peripheral lesion. The ability to close eyelids is lost in the peripheral lesions, and the mouth does not droop. However, if you see the central lesion, then you will see that the upper part is okay, but everything below here is the problem. So if it's a peripheral lesion, you're going to lose the whole thing. And if you are going to see the central lesion, then you're going to see something wrong in the lower end. Okay, so there are several causes to peripheral versus central lesions. Central is also known as supranuclear, so be aware of that during MCQs in case they try to trick you. And peripheral is nuclear. Okay, so multiple sclerosis, stroke, tumors, all of these things are well known to cause central lesions. Some of the peripheral lesions are Lyme disease. We know Borrelia burgdorferi, history of tick exposure, rash, arthralgias, hiking in Lyme endemic areas. So that's a common scenario. Otitis media. That's something that's often missed out. So that can lead to gradual onset, ear pain, fever, and conductive hearing loss. And Ramsay-Hunt syndrome, which is herpes zoster virus, also known as herpes zoster oticus, and you will have pain, vesicular eruption in the ear canal or pharynx, and sarcoidosis or GBS, and tumors, of course, such as cholesteatomas and parotid gland. Okay. Okay, so let's discuss Ramsay-Hunt syndrome. So as you can see here, very famous person who had Ramsay-Hunt syndrome. So you will see ipsilateral facial paralysis, otalgia, and a vesicular rash near the ear and auditory canal. So you can see that the patient can only smile on half of the, you can just do it this way, half of the face. And if you see here, it can only close eyes in half the face. So cannot close eyes. And when you ask the patient to smile, has droopy eyelid, has droopy mouth over here. I mean, can't properly smile, right? So if you see both upper and lower problems, so then you already know it's a peripheral lesion or lower motor neuron lesion. Okay, again, this was just showing you the vesicular rash. Just remember, this is important to know that the ear is innervated by different parts. So this can be a time with Ramsay-Hunt syndrome in questions. They can ask you, okay, so there's a rash over here. So tell us what nerve is, causing the pain. So you need to know how this works over here. Okay, I think we already covered that in great detail. Okay, so I just like you guys to know that the facial nerve has a long and circuitous root. So you will see that you can have a couple of lesions. You can have Bell's palsy, which is, remember, if you know the cause, it's not Bell's palsy. Bell's palsy is idiopathic. Never make that mistake. So, a problem here at the level of the internal auditory meatus. Here you would see Bell's palsy plus hyperacusis because you lose innervation to the stapedius. After the stylomastoid foramen, you can have a lesion here, which is going to affect all those motor branches. Okay. Yes, that's correct. Very good. Omaima, that's the correct answer. Okay, I'm going forward. Now, the vestibulocochlear nerve, that's cranial nerve number 8. Hearing and balance. If you have a lesion, it can cause vertigo, nystagmus, tinnitus, and hearing loss. Very important clinical correlation is a vestibular schwannoma. Here in the cerebellopontine triangle, you can see there are a couple of nerves. You already know that. So cranial nerve number 7, 8, and 5. However, the impingement will begin with the 7th, and then eventually, you can erode into the other adjacent nerves. So vestibular schwannoma, you can do an MRI and get that sorted out. Just have a sip of water. Glossopharyngeal. I appreciate that you guys knew that this innervates. There is parasympathetic innervation to the parotid gland, so I appreciate that. Now, sensory is taste and sensation for posterior 1/3 of the tongue. Something that we all tend to forget is carotid body and sinus chemobaroreceptors. That's very important. The eustachian tube itself, as well as the pharyngeal tonsils. It's motor for swallowing, salivation via the parotid gland, which it innervates via the parasympathetic, and elevation of the pharynx and larynx, i.e., the stylopharyngeus. And you will lose the gag reflex if there's a lesion to the glossopharyngeal. One more thing is, again, we talked about board review. So very important for you, USMLE, is something called the concept of referred otalgia, also for any head and neck exam. If you have a tumor at the base of the tongue or posterior pharyngeal wall, so different nerves will transmit that pain, and the patient may just say, well, I have pain in the external auditory meatus, external auditory canal. So if you have a lesion in the base of the tongue, remember here, we're here, right? So that's a glossopharyngeal nerve. So that otalgia will be referred via the glossopharyngeal nerve. However, if you have a lesion in the back of the throat, i.e. the posterior pharyngeal wall, so that otalgia will be referred via the vagus nerve. Okay. Now, the vagus nerve is quite big. It goes through a lot of body systems, and I think at this point we should just focus on the head and neck portion, and keep the rest of the discussion for another time if time provides. So, sensory taste from the supraglottic region, monitoring of aortic arch, chemo and baroreceptors. And again, as a tie into your embryology, this goes back to the concept of pharyngeal arches, which you can review on your own for your boards. The vagus nerve is also motor for swallowing, soft palate elevation, keeping the uvula midline, very important, talking, the cuff reflex, as well as parasympathetic to the thoraco-abdominal viscera. A lesion can cause dysphagia, dysarthria, loss of the gag reflex, of course, palatal collapse on the weak side, and that is what will also help the uvula deviate contralateral to the affected side, and the patient can also have vasovagal syncope. Okay, let me see if I can show you some pictures. Again, we talked about referred otalgia. Remember the cutaneous innervation of the ear, because that is a question they can use to trick you into checking how well you know your anatomy. I think this is beyond the scope. Now, cranial nerve number 11, accessory nerve. It supplies the sternocleidomastoid, which helps, and the trapezius, which help in head turning and shoulder shrugging. So if there is a problem, so this is the accessory nerve. I know it's kind of faint, but you can see the accessory nerve here. So if there's a lesion, so the shoulder will droop, as you can see here, on the affected side, and you cannot turn your head to the unaffected side. So you can see this scalp, I guess, is trying to look towards the other side. And for that, it's using the contralateral sternocleidomastoid. With the previous PBL case, I'm sure you guys already reviewed the lymphatics. That's another important thing to know. And just want to note that the hypoglossal nerve, vagus nerve, accessory nerve, and the laryngeal nerves are somewhat in danger when the patient is undergoing a carotid endarterectomy. Just want you to know that clinical correlation here. Okay, so cranial nerve number 12, hypoglossal. So it's motor of the tongue, except palatoglossus, which is innervated by cranial nerve 10, and the tongue deviates to the side of the lesion. And this exits the skull base through the hypoglossal canal of the occipital bone. So in general, any deviation due to lesions of the cranial nerves are away from the lesion except cranial nerve 10, because with that, the uvula deviates to the side of the lesion. Okay. Sorry, my bad. I just need to rephrase that. So the palate droops on the same side and the uvula deviates away from the lesions. Just wanted to correct that before we go. Okay, just quick summary of the pupillary reflex. So we discussed that. The jaw jerk reflex is basically a stretch reflex stimulating masseter contraction. And I think, let's go forward. Yeah, so we already discussed that it's not common. And if it's present, it's the sign of an upper motor neuron lesion. Okay, quick cranial nerve scenarios. If the patient has a trauma, fracture of the ethmoid bone and cribriform plate, and CSF leak from the nose, that's a common scenario in cranial nerve 1. Cranial nerve 2, the patient may have neurofibromatosis, can have optic glioma, and abnormal pupillary reflex. So that's another common scenario. Cranial nerve 3 can be injured in uncal herniation or aneurysm of the posterior communicating artery or the posterior cerebral artery. Cranial nerve 4, the classic scenario would be difficulty walking, head downstairs, head tilt away from the side of the lesion, and neck pain. Cranial nerve 5, a tumor can affect it, and the patient will have difficulty swallowing, jaw deviation to the affected region. Cranial nerve number 6 is interesting because the patient can actually develop, this can be also affected in the case of cavernous sinus thrombosis. Let's say you have a pimple in the danger triangle, which we discussed, and now the patient has proptosis and medial eye deviation, and this all can, be signs of cavernous sinus thrombosis. If there's a hiker cannot raise eyebrows and has dry eyes and hypersensitive to sound, you know that this is likely going to be a peripheral facial nerve lesion. Cranial nerve 8, patient can have neurofibromatosis too, and abnormal MRI in the auditory canal and sensory neural hearing loss, and then you may see a schwannoma. Okay, cranial nerve 9, you will have loss of the carotid sinus reflex and loss of taste in the posterior 1/3 of the tongue. Cranial nerve 10, contralateral uvular deviation and inability to look down. If the patient has cervical lymph node surgery and ipsilateral shoulder weakness, so please remember your accessory nerve can be damaged. Ipsilateral tongue deviation and atrophy and fasciculations with the tongue deviating to the lesion side can indicate hypoglossal nerve damage. So I spoke a lot. We've covered a lot of ground, so let's see if you guys can answer this question. So please create the polls and let's see how many of you answer.
One
Please,
second.
the
Also, there's
remaining.
a question in chat.
Oh, okay. But please create the poll.
Yeah, I'm working on it right now. Hopefully this works, inshallah.
So, so you don't need to write the question. You just need to put the option A, B, C, D, E, and just put question 1 there so they can choose whatever
Yeah.
they want.
There should be an invitation to the participants to use the poll right now. I just made it.
Thank you so much. the interest of time, we'll just take 1 minute and then you can just display the poll results.
Dr. Affan, I have a question on the previous slide.
Can you display the results?
Yeah, no problem. I don't know how to display it, but I can say what the results are, I guess.
Okay, that works.
So 57% on A, 14% on B, and 29% on E. So the majority is for A.
And what's the second most common answer?
E.
Okay, that is very interesting. So can someone who chose A explain? Please, let's be interactive so we can get this over, because let me tell you, I need to hear that and explain the reasons. So please, if you can just speak up and we can get this done. Please.
Just based on like, I kind of skimmed through the question and it looked a lot like a, what's it called? The vestibular schwannoma.
Mm-hmm.
It's like at the angle between the pons and the medulla or something like that. Um, and yeah, it would cause stuff like the spinning that they have, um,
Okay.
and the hearing loss that the patient also has as well.
Okay. So you put A. And what was the second answer? E?
Yeah.
Okay. So who's chose E? Could you please explain?
Doctor, I thought it was the benign
Mm-hmm.
proximal positional vertigo.
Okay.
Yeah.
Very good. Okay. So unfortunately, the answer is, so no one answered C?
No, no one put C.
Okay. Okay. Is there, okay. So anyways, I think that's where the benefit of these questions comes. So this is a question from step one resource. Um, okay. So let's go through this question together. So what are, if someone can be the volunteer, Samir, can you go ahead? Or anyone else?
Should I read the question?
No, just give me what are the clinical things or what is wrong with this patient? What is the history of presenting illness? Just give me words like
Yeah, sure.
episodic vertigo. I'll give you one.
Yeah, so she has, like I said, episodic vertigo that lasts for 1 to 2 hours, leads to unsteadiness. And additionally, she has a 2 year history of these similar episodes. She also hears a mechanical humming, so sound hallucinations or something like that. There's no other symptoms such as headaches, ear pain, discharge. Temperature is normal, blood pressure is normal, and the pulse is also normal. However, importantly, air conduction is greater than bone conduction, which we know is normal. And importantly, during the Weber test, the sound actually lateralizes to the left ear. And that's all the clinical features.
Okay. So thank you for doing that. So unfortunately, the answer is E. Sorry, the answer is C. So can someone tell which condition has elevated endolymphatic pressure?
Meniere's disease?
Yes, very good. That's an important disease to know. Now let's go over this question. So this patient, as Samir pointed out, has episodic vertigo, tinnitus, and sensory neural hearing loss. Remember, guys, they may not just say that. They can try to play around with the question and give you the Rene and Weber test. So it's your job to interpret that. So when the base of a tuning fork is placed against her forehead, the sound is heard more prominently in the left ear. So sensory neural hearing loss, episodic vertigo, tinnitus. She also hears a mechanical humming sound in her right ear. So never just expect them to say a ringing sound. And don't be distracted by all the extra fluff. So you need to focus on always pick out what's clinically happening and then go over this. So um, does that make sense? What signs in this case would be different? Yes, so now we'll go over the options. So Meniere's disease is a disorder of the inner ear system. It's characterized by increased volume or pressure of the endolymph, i.e., it's also known as endolymphatic hydrop. So that's why the answer is C. Now, what happens once you have this extra pressure within the endolymphatic system? So you distend that system, which damages both the vestibular and cochlear components of the inner ear. And you have that classic triad, episodic vertigo, which can last from 20 minutes to a day, and this is commonly associated with nausea and vomiting, which this patient had. So we missed that part. The other thing is sensory neural hearing loss. It starts off with the low frequencies at first and then progresses to permanent hearing loss over all frequencies. And this is something that worsens over time. The tinnitus is typically described as being low frequency, and the patient also has something which we call aural fullness, aural coming from the ear, so something that's AURAL, by the way, not ORAL. So that is aural fullness or feeling full in the ear. Now, yes, the other choices. Let's go over that. But first, let's, I guess, discuss this. So the diagnosis is based on clinical findings. However, you can do an audiometry to characterize the hearing loss and follow its course over time because that's an objective measurement that you can use. You can also do an MRI in these patients, as some of you pointed out that this could have been a schwannoma. So an MRI could have helped us out with distinguishing central nervous system lesions. The initial management includes restriction of sodium, caffeine, nicotine, and alcohol. And if the patient comes in with acute symptoms, this may be a bit advanced. You can give them benzodiazepines, antihistamines, and antiemetics. Diuretics can also be given to these patients. Now, coming back to the choices, a benign tumor compressing a cranial nerve. Now, vestibular schwannomas can cause unilateral sensory neural hearing loss. That is true. Sometimes with imbalance and tinnitus, right? So that's where both conditions are same. However, symptoms are usually persistent and progressive rather than episodic. Does that make sense? Because the tumor doesn't go away, right? So it just keeps on growing. So we don't see that progression in this case. Now, if we go to B, central nervous system demyelination, that is pointing towards multiple sclerosis. Now, multiple sclerosis can actually cause episodic vertigo and sensory neural hearing loss. However, remember, we are not seeing other manifestations of multiple sclerosis such as paresthesias, weakness, visual disturbance, optic neuritis, i.e., or urinary incontinence and all that stuff. So that's out. C is the correct answer, which we discussed. D, inflammation of the membranous labyrinth. So I agree that like Meniere disease, labyrinthitis, what's another name for labyrinthitis? Just speak it out, please.
Is it
Hello?
vestibular neuritis?
Very good. That's correct. Very good. Because in the MCQs, they can use that interchangeably. So, labyrinth. So that's option D, right? It can cause vertigo, hearing loss, and tinnitus. However, remember the symptoms last a few days to several weeks. But this is like a long, long. She has been having this for the past 2 years. Okay. Now finally, the second favorite option, lose calcium debris in the semicircular canals. As you guys correctly pointed out, that's benign paroxysmal positional vertigo. Benign paroxysmal positional vertigo. Just think of that name, right? So it is brief, i.e., it is paroxysmal, often intense. That's why your patients come to you, and the patients have vertigo triggered by changes in head position. We don't see that here. She has not indicated that that is a problem when she changes her head. So it's not positional. So it cannot be positional part of that BPPV acronym. And patients can have headaches or feeling of fearfulness. But remember, tinnitus and hearing loss are not typical of BPPV. So does that make sense?
Yes.
Okay, very good. I'm happy that we got this question wrong because we got an opportunity to discuss a lot. Okay, and again, some of these questions are challenging, so please don't feel down. I'm sure you guys will do wonderfully well in the final, inshallah. Okay, so again, vertigo, kind of syncopal attacks, hearing loss, tinnitus, and increased endolymphatic pressure. So this is the classic triad which we discussed. And now let's go over some of the common causes of vertigo. So we already discussed a host about Meniere disease, right? So remember that triad. So sensorineural hearing loss, tinnitus, oral fullness, and nausea and vomiting. BPPV is again the otolith dislodgement. And I'm sure you guys are familiar with the Dix-Hallpike maneuver, which can elicit nystagmus. Vestibular neuritis, also known as labyrinthitis, is acute vestibular nerve inflammation. It is usually preceded by an upper respiratory tract illness, i.e., a viral syndrome, and then the patient has sudden onset vertigo and nystagmus. And this is usually a single episode that can last days. Migraine, very important. Migraine can actually lead to vertigo as well as other phenomena such as visual auras and scintillating scotoma and so on and so forth. Brainstem and stroke. So that's a central cause of vertigo that is important to be concerned with whenever you're dealing with vertigo. Perilymphatic fistula is a very rare thing. I don't think we need to go over that. Okay, so this is something that I was told to focus on. So vertigo can be peripheral versus central. Now, ignore whatever is written, but we'll work through this together. Now, nystagmus is an important component of distinguishing peripheral versus central vertigo. Remember that the peripheral vertigo is never purely vertical, while central vertigo can be, all over the place. It can have any trajectory. And nystagmus or peripheral vertigo will be inhibited by gaze fixation, while central vertigo nystagmus will not be inhibited by fixation of the gaze. And other possible neurologic signs will also help you lower that, will also help you, narrow your differential. So hearing loss or tinnitus may be present, should be an R, and walking is usually preserved and there are no other CNS symptoms. So that's usually peripheral vertigo. Central vertigo, hearing loss and tinnitus are usually absent because remember, this is more of a central lesion. And remember, the central nervous system is very important to help you maintain your posture, so postural instability, and look for other CNS signs such as signs and symptoms of stroke. So that is going to point you towards central vertigo. So very important concept. Okay, next question.
Okay, I'll make a poll. 1 second.
Mm-hmm. And I appreciate those people that are answering. I really do.
Okay, I made the poll, guys.
Mm-hmm. So by that time, they had time to answer the questions. We'll just give them like 30 seconds because this is a short one. Please lock in your answer so we can go ahead. Okay, I think we can know the answers by now.
Okay. Um, two options are actually have equal amount of people, which is C and
Mhm.
D,
Okay,
and then the rest are on A. Oh,
okay,
now
because
D changed. D is now the most popular answer.
okay, I'm so glad. So you see, that question really did help us. So the correct answer is D. Okay, so that is good. So again, let's go over the options. Bernier disease, A. So that's wrong. So the patient would have episodic vertigo, tinnitus, and fluctuating hearing loss. The vertigo is supposed to be episodic, not continuous for 2 weeks, and there is no mention of tinnitus or ear fullness in this case. B. Vestibular schwannoma. Um, the onset should be insidious and the vertigo is rare. And MRI in this case does not show a mass at the cerebellopontine angle, so that's ruled out. C, BPPV, this patient has no episodes of vertigo triggered by head movement, and it's not paroxysmal; it's continuous here. So that's wrong. So D, that's correct. Inflammation of the inner ear, often post-viral, as we discussed, associated with nausea, vomiting, and unilateral sensory neural hearing loss. And that's right. So bilateral vestibulopathy, this would cause imbalance and problem seeing, especially in the dark, which is not the answer. So very good. I'm very proud of you guys. The answer is D. Very good. Okay. Again, so just want you to know that there can be a lot of causes of vertigo, but once you divide them into peripheral versus central, remember the duration, okay, and the triggers, and you will be able to figure it out. Okay. Another thing that I was requested was otitis media. So we'll be going over this. Okay, so some of the common agents are strep pneumo, non-typable Haemophilus influenzae, Moraxella catarrhalis. Now, this is usually a clinical diagnosis. You have middle ear effusion, and how do you see that? You see poor TM, tympanic membrane mobility or insufflation. That's the thing they can add in your MCQ. So what insufflation means is you basically pump some air and see if the tympanic membrane moves. So it's as simple as that. And in this case, it doesn't. You have tympanic membrane inflammation, bulging of the tympanic membrane. You have non-specific signs such as acute fever, otalgia, tympanic membrane erythema, irritability, difficulty feeding or sleeping, feeding for babies. So some of the risk factors include anatomical reasons, such as straight and narrow eustachian tube, especially in children, lack of breastfeeding, daycare attendance, because they get exposed to a lot of stuff, smoke exposure, which can not only affect the lining of their ENT system, but it can also lead to allergic reactions, which can also, reduce the drainage through the eustachian tube and all of that stuff. The initial treatment is amoxicillin. You can also add clovulinate, especially if there is some resistance or the patient does not get better. Some of the complications, very high yield to know these complications can be tympanic membrane perforation. When that happens, the patient is going to be like, I suddenly had relief from my pain, and the patient would have temporary conductive hearing loss. So these things point to tympanic membrane perforation. Conductive hearing loss, of course, due to the presence of fluid and or rupture of the tympanic membrane, mastoiditis, as well as meningitis. We already discussed that the eustachian tube is shorter, straighter, and more horizontal in children than in adults, which leads to poor drainage. Here you can see what happens when the patient has acute otitis media. You see the bulging tympanic membrane, purinal fluid collection, and you lose that pearly white appearance of the tympanic membrane, and here's the light reflex as well. Now, some of the suppurative complications of otitis media are here, as you can see. Just it's very simple, don't panic. Just remember what's below, what's on the side, what's above, and you'll be good to go. So, what's above? You have the meninges, right? So first of all, you have the bone, right? Which it can affect. Then you have the meninges, so meningitis, and then a brain abscess. Then it can affect the mastoid cells, right, which can lead to mastoiditis. So just remember, think anatomically, and you'll be good to go. Now, we have something called serous otitis media, which I hope you guys remember from your PBL case. So this is acute otitis media, and this is serous otitis media or otitis media with effusion. Just want you guys to see the difference between the tympanic membranes. Know that you can insert a tympanostomy tube, as you can see here, and drain and ventilate that middle ear. Okay. Now, otitis media with effusion, as was in our Peeble case, is also known as serous otitis media, and this is usually without inflammation. That's why you don't see bulging and erythema of that tympanic membrane. It's usually in young children, and it's usually in the setting of viral infection and or after acute otitis media. The effusion is classically non-purulent, okay? And the clinical symptoms are, mild discomfort, no fever, or severe ear pain. Examination will reveal ear fluid levels, poor TM mobility because of course there is an effusion there, and no tympanic membrane erythema or bulging. This is now coming to the management. It is usually self-limiting. Okay. However, you will need to treat the patient if there are other symptoms, right, such as fever, pain, or purulent effusion, because now it kind of turned into acute otitis media. If the effusion is bilateral, you need to do something because you don't want both ears to be plugged up. And if the effusion persists for 3 months, because that's too long of a time to wait. If it is chronic, i.e., more than 3 months, that becomes a problem because if the children do not hear something, then that will lead to speech delay and long-term hearing loss. That kind of ties into your BHS, something I never expected to do in an HNS session. Okay. You can also place tympanostomy tube, which we saw, which will ventilate and drain the middle ear. Now, a common scenario in board questions is having a tumor. That can also lead to a sterile effusion in the middle ear. A tumor here obstructing the eustachian tube can also lead to serous otitis media or middle ear effusion. Okay, can you guys hear me all right?
Yes, doctor.
Okay, because the mic thing doesn't move, so just making sure. Okay, coming to, I guess, everyone's favorite part, the Weber and Rene test. So with the Weber test, you place the fork on the vertex and you're looking for lateralization. Now, the black bar here represents air conduction. This is the background noise that you are hearing, and the red is the bone conduction. Now, in case the patient has conductive hearing loss, right? So what is going to happen? This can be either something wrong with the tympanic membrane, such as impacted wax or rupture. It can also be ossicular erosion or sclerosis or something all the way happening to the cochlea. I mean, before the cochlea. So sound from the ear is hard to hear. Background noise in the affected ear is little, right? So all vibrations will sound louder. So once you place that vibrating fork on the vertex, you will hear the vibration in the affected ear. So that's why it localizes to the affected ear, because in comparison to the background noise or the air conduction, the bone conduction is doing pretty well. Now, sensory neural hearing loss. If you cut that or if you transect that sensory output going away from the ear, so then you will not hear anything in that ear, right? So cochlear nerve or brainstem issues, patient with vestibular schwannoma, so all hearing will be lost. You will not have bone conduction or the ear conduction in the affected ear, and the sound will localize to the unaffected ear. This is just another image, but I think we've gone through that. Now, once we come to the Rene test, once we come to the Rene test, usually air conduction is more than bone conduction, so you can hear outside, even if you cannot hear from the mastoid anymore. Now, if we see the example of conductive hearing loss, so the bone conduction is much better than ear conduction, and you will hear more from the mastoid. Now, if we go towards sensory neural, the overall strength of the vibration that you'll hear will be low, right? But like normal, air conduction is greater than bone conduction because, again, that's a normal thing. There is nothing that is causing conductive hearing loss. Okay, question 3.
Okay, 1 second. Okay, I made the poll, guys.
Okay, let's look at the polls.
Okay. Everyone actually put A.
Oh, wow. So this must be an easier question. I'm so glad. Okay, very good. So the answer is A, which is cochlear hair cell loss. So this elderly patient, as you can see, was brought in for evaluation for social withdrawal, and now he has trouble understanding speech, especially when there is competing background noise. So this is a classic scenario for presbycusis or age-related hearing loss, which is bilateral progressive sensorineural hearing loss. High frequencies are affected first, so that's why patients find it difficult to understand higher pitched voices such as women and children, and tinnitus often develops and is typically a continuous ringing, rushing, or buzzing. So very good. Okay, let's go
I had a
ahead.
question, doctor.
Yes.
Is this like an extreme case of presbycusis? Presbycusis, sorry. Like, does it usually, or is it normally this bad for the patient?
Yeah, so the thing is, presbycusis is quite insidious. So, so once it sets in, it's a gradual process and it gets progressively worse. Now, the thing is, why it seems so heightened here is because the wife is taking this patient for kind of, if you see, like kind of like a psychiatric evaluation in this case, because he no longer listens to me. And that's why I think it seems very heightened, but it's a progressive condition that gets worse over time, unfortunately.
Okay. Yeah, makes sense. Thanks.
Mhm. Okay, next question.
1 second. One second, sorry, something is going wrong with my device.
That's okay. So, okay, we can do it the old style way. That's okay.
Okay, I made it. Supposedly, it should be working.
Okay, inshallah. Hey, have the answer started to kick in?
Yeah, right now majority on D.
Okay, very good. Okay, so let's close the poll, I guess, and let's talk about this question. So very good, the answer is D. Would someone like to explain why?
I put D because it seems like a clear-cut case of bacterial sinusitis, rhinitis. Plus, I think it's also been more than a week, which is probably the criteria for antibiotic use, if I remember correctly. Um, and yes, that's kind of my rationale for why I chose that.
Okay, thank you so much, Samir. So that's the correct answer, and that's a great way to put it. So if you notice, Samir said that this is a problem with the nose. So he mentioned rhinitis, and he also mentioned sinusitis. So a combined term for that would be rhinosinusitis, and that's what we're commonly using nowadays. So this patient has worsening daytime cough and purulent nasal discharge consistent with acute bacterial rhinosinusitis. This is commonly proceeding an upper respiratory tract illness, so especially a viral one. And once that resolves, the patient gets the sinusitis. So this is what they call the double sickening effect or biphasic illness. So symptoms worsen after initial improvement. So always remember that in your questions. Now, in this case, thank you, Samir, for mentioning the criteria. So, this is a clinical diagnosis. So, we have certain criteria to it, such as symptoms, such as cough, congestion, and all that stuff, persistent for greater than 10 days without improvement. The symptoms were severe in onset, so such as fever, drainage for more than 3 days, or symptoms worsening following initial improvement. That's the biphasic illness. So, once you add in all of those things, and if you have at least one of those three criteria, so then you can label the patient as having ABRS or acute bacterial rhinosinusitis. Most cases are due to non-typable Haemophilus influenzae or strep pneumo. The patient usually has worsening symptoms such as progressive cough, fever, and all that purulent discharge. We usually treat with oral antibiotics such as
Amoxicillin.
very good, very good. So that's amoxicillin clobulinate plus minus. You can add it or not, depending on your local data. And that's the correct answer. And let me see. Yeah, it's definitely not allergic. And remember that you don't need a sinus fluid culture for uncomplicated ABRS, especially if it responds to your empiric antibiotics, which is your amoxiclav. Okay, next question.
Doctor, it seems that what's it called? The poll thing has a limit for each meeting, so I can't do any more polls.
Okay,
So
that's
if you
okay.
could do this one like, yeah, traditional style, I guess.
Okay, that's okay. So just type in your answers in the chat and I'll know. Oh, yes, that's a good idea. So you can send your answers directly to me. So that way no one knows who you're sending the answer to. So please do that promptly. This is a smaller question. Okay, very good. Very impressive, guys. So great job. So this is more of you need to respond in the next question, okay? But this is correct. So this is chronic rhinosinusitis. Yes, it is C. Very good. And as you can see that you have fluid accumulation here, and that has kind of filled the sinus here. Okay, and the clinical picture kind of goes with it. Okay, so again, anatomical correlation. So here you can see the ethmoid sinus, the maxillary sinus. Here you can see the middle turbinate. Here you can see the inferior turbinate, this curved-like thing. And here you can see the nasal septum. And here are your eyeballs. Okay, and you can see that the eye socket is intimately related to the sinuses, right? So if you remember your PBL case, an inflammation of the sinuses can eventually lead to contiguous spread into the eye socket and eventually lead to orbital cellulitis. So that's an important tie-in as well. Again, on the X-ray, you'll see this is normal and this is what happens when you have sinusitis. Now, I simplified this question because one of the options in this question was having polyps. So I just wanted to show you polyps. So as you can see, this is a polyp here, this is a polyp here. And of course, I think this requires some skill to distinguish. Here you can see ethmoid sinusitis as well. Here's the middle turbinate, inferior turbinate. But there's a polyp here, there's a polyp here as well. Okay. So very good. I really, really appreciate that you guys got everything correct. So fever, nasal congestion, purulent nasal discharge, maxillary tooth discomfort. I think I should have mentioned that too. So again, remember how, okay, so an infection over here can also affect your teeth, right? An infection here can also lead to the teeth. And the patient may just say, oh, doctor, I have toothache. And that may be one of the signs that can actually lead you to thinking about sinusitis. So be on the lookout always. Okay. Does someone know what this is? Any guesses? Okay.
Retinoblastoma?
Okay, very good. So once you lose that oblastoma, you're on the right track. This is the retina. Okay, very good. Because one of the things I was told was to cover the histology. So this is your sclera, this is the choroid, this is the pigmented epithelium, the outer nuclear layer, and eventually this is the tiny wave-like things, they're the optic nerve fibers, and then eventually have the vitreous body. So know your layers of the retina well. I know you probably have not taken the eye, but just wanted to give you a heads up there. Here you can see the fovea, right? Okay, let me just label it for you. Okay, here you can see the fovea. This is the region with the most acute vision in the retina. You can see this depression. So this is the fovea. And what else do I need to add? It is packed exclusively, almost exclusively with cones, and this is where you see you have the best visual acuity. Okay, does anyone know what this thing is? So this is your vitreous and okay, let me see the chat. Okay, very good. That's the correct answer. Very good. Optic nerve, cranial nerve 2. Okay, so that's how this works. So this is the optic disc. Here are the fibers, and this is this is the retina. Okay, next question. Oh yes, please send me your um, answer choices via text personally. Direct message. Okay, that's an option. What else? Okay. Anyone else? Okay, good. Okay. Okay, so very good. So I'd like someone to tell me why they chose A, and I'd like someone to tell me why they chose C. Real quick, please.
Okay, for A,
Mm-hmm.
I just know that the patient is diabetic. I don't know much about the eye, but I
That's
do know
okay.
that patients with diabetes are, susceptible to diabetic retinopathy.
Mm-hmm.
So I don't know what the non-proliferative part means, but I just assumed maybe it could be diabetic retinopathy.
Okay, that works. Okay. So, Yara, could you please go ahead?
Okay, so I think absent red reflex means there's something that is blocking the view. So
Very
it's
good.
here, there's something like a bleeding.
Mm-hmm. Very good. So the correct answer is actually C. No, I agree. I know you haven't taken ophthalmology, but I like the way Yara put it. Okay. So let me just see if we can kind of do this real quick. So if this is your eye, right? And this is, let's say, the front. Okay. And this is the back of the eye. Here is your favorite nerve, the optic nerve, let's say. Now, if I am to shine my light from here, okay, so remember the red reflex, absence of the red reflex, you probably heard this in the case of retinoblastoma. Everything that affects vision here, behind, from here to here, will lead to an absence of the red reflex. If the retina falls, retinal detachment, you'll not see the red reflex. If we have blood in this cavity, vitreous hemorrhage, you won't see the red reflex. If there's a tumor here, you won't see the red reflex. If you have cataracts, then you've already, you know, made kind of like you have an opaque structure over here, i.e. like a cataract lens. Okay, you won't have the red reflex. So anything that affects the transmission and reflection of light off the retina will affect the red reflex. So very good, Yara. I really appreciate that response. Very good thinking. Okay. Now I guess we're heading towards the final part. Let me just close the annotation. Okay. So I know you guys haven't taken um OFTA, but here is a summary slide. Okay. Let me just remove the annotation, please. Okay, I don't know how to get rid of that, but just give me 1 second. Discard. Okay. I think you guys can still read the slide, right?
Yeah, it's
Okay.
visible.
Yeah.
Okay. I'm sorry for it. I don't know how to get rid of that. Okay. Okay, got it. Okay, anyway, so here are some of the emergencies that you will encounter during the ophthalmology lectures. So what I did is I've summarized them in a table for you. I understand you haven't taken ophtha lectures yet, but once you do, you can always refer back to this table and add more or reduce as you like. Just some of the things I'd like to highlight are ocular trauma. So remember that this can also lead to that fracture which we talked about when you affect the lower part of the eye socket and then you have the inferior rectus entrapment syndrome. When you're talking about chemical ocular injuries, so remember that alkalis are worse because they are more penetrating. Orbital cellulitis, you guys already took that in your PBLs, so remember that. And the spread can be either via dental infections or hematogenous spread from distant or systemic infections, as well as trauma. Endophthalmitis is kind of like infection introduced within the eyeball. So intraocular surgery, penetrating trauma, or hematogenous spread from systemic infections. Acute angle closure glaucoma. So that is something that I'm sure you guys will learn about, but be very good with acute angle closure glaucoma because it can serve as a good tie-in with somewhat of anatomy but also of clinical with pharmacology because of all the agents that you will use to deal with acute angle closure glaucoma. Optic neuritis, we kind of touched over it briefly when we talked about multiple sclerosis. Giant cell arteritis, remember high dose corticosteroids are your go-to thing to do, especially when you suspect someone with giant cell arteritis. You probably took this in MSI as well. Central retinal artery occlusion, very, very important. Sudden painless vision loss. And that's one emergency that you must know. I can't see what's below that. What does it say? Retinal detachment? Yes, retinal detachment. That's very important. You will see the curtain sign, and I'm sure you guys will take that in your opto lectures and homonymous hemianopia. Whenever you see that, you need to think of getting neurology involved and getting imaging because it can be lesions, masses, or stroke, a host of different things. So be aware of those things. Okay, so we have reached the end of our talk, and okay, and is it possible to stop recording, please?
Oh yeah, I think I can stop it from my